I want you to picture something with me. And honestly, it's not a pleasant image, but stay with me for a second.
Okay.
You're in a hotel room in, let's say, a remote village in the Italian Alps, or maybe a bustling neighborhood in Tokyo.
Right. Far from home.
Exactly.
Yeah.
You've planned this trip for 6 months. You have the itinerary, the restaurant reservations, the perfect shoes, but then you wake up at 3 a.m. and the itinerary is just gone.
Yeah.
The shoes don't matter because something in your body has gone completely haywire.
That is a visceral fear. I think we've all felt a version of that. It's the traveler's paradox. You go away to feel free, but when you get sick, you suddenly feel incredibly trapped.
And it's not just the illness, right?
Yeah.
It's the silence.
Mm-hmm. The inability to communicate what is happening to you.
Exactly. It's that specific cold spike of anxiety where you realize, I don't know how to say, my appendix feels like it's exploding in Japanese.
Yeah.
So today, we aren't talking about ordering wine or asking for directions. We were doing a deep dive into medical English. This is a linguistic survival guide.
And we should set the stage here immediately. This is not a medical show.
Right.
I am not diagnosing your appendicitis. We're analyzing the language tools that, bridge that gap between I'm scared and I'm getting help. We're going to break down the nuance of pain, how to handle a doctor's office, pharmacies, and even emergencies.
The mission today is really to move from panic to preparation. Because when you're sick, your brain isn't working at 100%.
Yeah.
You need a script. You need to know that there is a difference between saying, I hurt, and I have a sharp pain.
It sounds like semantics, but it's actually diagnostics, and that's where we have to start, the nuance of discomfort.
Right. So in casual conversation, I feel like we use words like ache, pain, and sore completely interchangeable.
All the time.
If I go to the gym, I'm in pain. If I sit at my desk too long, I'm sore. It's all just a bad feeling. But you're saying a doctor hears those words very differently.
Drastically differently. When you walk into a clinic, you are the narrator of a mystery. The doctor is the detective. The specific words you choose are the clues. And if you give the wrong clue, you send that detective down the completely wrong path.
Okay, so let's look at the first clue then. Ache. To me, an ache is just, well, something that hurts.
But linguistically and medically, ache has a very specific profile. It's defined as a dull, constant pain.
Dull and constant.
Those are the key words. Dull, constant. It's not a scream, it's more like a hum.
Like a background noise that just won't turn off.
Exactly. Think about a stomach ache or a standard headache. It's not usually preventing you from walking, but it just wears you down. It's oppressive.
Right.
So if you tell a doctor you have an ache, they're thinking about chronic issues, inflammation, tension, maybe a slow developing infection. They're not usually thinking emergency surgery.
Okay, so ache is the low simmer setting. Now, let's contrast that with pain, because in my head, pain is just the umbrella term for everything.
In a medical context, pain is much more aggressive. It's defined as sharp and sudden. It grabs your attention. It creates a physiological spike. Your heart rate goes up. Your pupils might dilate. It's an event.
So, chest pain. That's the classic example.
That's the perfect example. If you walk in and say, I have a chest ache, the doctor might think you pulled a muscle lifting your suitcase.
Okay.
If you say, I have chest pain, the crash cart is on standby. You are triggering a completely different protocol.
Wait, but let me challenge you on this, though. What about a migraine? That feels pretty sharp to me, but we call it a headache.
That is a fantastic point, and it's where English gets tricky. I mean, a migraine is technically a headache, but if you were describing it to a doctor, you wouldn't just say, my head aches.
No, I wouldn't.
You'd say, I have a sharp stabbing pain behind my eyes. You qualify it. But the baseline distinction, it still remains. Ache is the background fog, pain is the lightning strike.
I like that analogy, fog versus lightning.
Yeah, right.
Okay, now, the third one is the one I think trips people up the most, especially non-native speakers. Yeah. Sore.
Sore is fascinating because it's almost entirely mechanical, it's functional.
Mechanical?
Yeah, the definition is pain specifically related to touching or moving a body part. It's reactive.
So it doesn't hurt if I'm just sitting here doing nothing?
Generally, no, or at least the main sensation comes from interaction. Think of a sore throat. It hurts when you swallow, it hurts when you talk.
Or if I worked out way too hard yesterday, my legs are sore.
Yes.
They're fine if I'm on the couch, but the second I try to stand up.
Exactly that. You're telling the doctor, this hurts because of movement. And that tells them it's likely muscular or soft tissue, or maybe inflammation of the surface. It usually rules out deep internal organ failure. Do you see how much work these three words are doing?
It's actually kind of wild. By picking one of three words, You're basically sorting yourself into a triage category before the doctor even touches you.
You're directing their attention.
Okay, so we have the vocabulary. We've got our fog, which is ache, our lightning pain, and our reactive movement, sore.
Mm.
Now let's walk through the actual door. We're going to the doctor.
The consultation. This is a high-stress environment. You're vulnerable. Maybe you're wearing a paper gown. The room is cold. And doctors, I mean, everywhere in the world, they're busy. They just want the facts.
Right. So we have a script here from our notes that lays out a typical interaction. And when I first looked at it, I thought, wow, this is robotic. But maybe that's the point.
It is absolutely the point. When you're nervous, you tend to babble. You want to tell the story of your trip, how the food was weird, how you slept funny.
Right, the whole story.
And the doctor doesn't need the backstory yet. They just need the headlines.
So let's run this. I'll be the patient, you be the doctor.
All right, I'm walking in, looking at your chart. What seems to be the problem?
I have a fever and I feel dizzy.
I see. Anything else?
I have a rash on my arm.
Okay, I will write you a prescription.
Scene. Okay, that was 10 seconds. It feels incredibly abrupt.
It is abrupt, but look at the information density. You said, I have a fever. That's objective. I can measure that. Then you said, I feel dizzy. That is subjective. I can't measure that. I have to trust you.
Why does that combination matter so much?
Well, fever plus dizziness suggests a systemic issue. An infection, heat stroke, the flu. You've given me a whole body picture in one sentence.
And then I threw in the curveball. I have a rash on my arm.
And that changes everything. Fever plus dizziness plus a rash. Now I'm thinking allergies or maybe something viral like measles or dengue, depending on where we are.
Wow.
The visual cue is critical. If you hadn't mentioned the rash, I might have just treated you for the flu.
It's interesting that the script includes pointing out the rash. I feel like travelers often rely on pointing. It hurts here. Look at this.
Mm-hmm.
Is nonverbal communication enough?
It's a crutch, but it can be a dangerous one. Pointing to your stomach and groaning could be food poisoning, or it could be appendicitis. Pointing gets the location, but the words get the sensation. That's why you need to pair the pointing with the vocabulary. Stomach plus sharp pain is very different from stomach plus dull ache.
Right. The pointing gives the where, but the words give the what.
Precisely. And the interaction ended with the magic words, I will write you a prescription.
The golden ticket.
Yeah.
Which moves us out of the doctor's office and into the next circle of, well, healing. The pharmacy.
And this is where cultural differences really smack you in the face. In the US, you can walk into a supermarket and buy 500 pills of ibuprofen. In parts of Europe or Asia, that's simply not possible.
So you can't just browse the aisles.
Often, no. You have to go to the counter and ask for everything. The pharmacist is a real gatekeeper.
So the first phrase we need to have locked and loaded is, do I need a prescription for this medicine?
Yes. This is the clarifying access question. It saves you so much time and embarrassment. You don't want to be the person arguing with a pharmacist in broken Italian about why you can't have the strong stuff. Just ask first.
And what if I don't know what I need? Like, what if I just have a cold?
Then you use the advice-seeking phrase, can you recommend something for a cold? But here's the pro tip that we need to talk about. Brand names versus chemical names.
Oh, this is a huge one. I learned this the hard way. I
Yeah.
went into a pharmacy in Spain asking for Tylenol, and they just looked at me like I was speaking Martian.
Exactly. Tylenol is a brand name. It's marketing. The drug is acetaminophen, or in most of the world, paracetamol.
Right.
If you ask for paracetamol, you will get help in London, Lima, or Laos. If you ask for Tylenol, you're gambling.
So part of your prep should be knowing the generic names of the meds you usually take.
100%. Write them down. Acetaminophen, ibuprofen, diphenhydramine. Those are universal scientific languages.
Speaking of diphenhydramine, which is Benadryl for us Americans,
Mm-hmm.
that brings up a specific word the notes highlight. Drowsy.
Yes. The question you must ask, does this make you drowsy?
Now, obviously, drowsy means sleepy, but why are we flagging this as a survival phrase? It seems like such a minor side effect.
Context is everything. If you're at home and you get drowsy, you go to bed. Fine. But if you're a traveler, you might be renting a scooter in Bali. You might be navigating the Tokyo subway at rush hour. You might be hiking solo.
Oh, I see. It's a liability issue.
It is a safety issue. Being drowsy in an unfamiliar environment makes you a target, and it makes you accident prone. If the answer is yes, it causes drowsiness, you need to change your plans.
Right.
You don't drive, you don't go out alone, you take it and you lock your hotel door.
That is such a good point. Our cognitive load is already so high when we travel. Lowering our alertness with medication is risky.
Exactly. You need to be sharp.
Okay, speaking of needing to be sharp, we have to go to the dark place now. We've done aches, the doctor visit, the pharmacy run. But sometimes it's not a slow burn. Sometimes it's a crash. Emergency protocols.
This is the part of the conversation where the tone shifts. We aren't negotiating comfort anymore. We are negotiating survival. And the biggest enemy here isn't the injury, it's the panic.
The freeze response.
Right. When something traumatic happens, a car accident, a collapse, your prefrontal cortex, the part of your brain that handles language and logic, it essentially goes offline. You revert to lizard brain, fight, flight, or freeze.
And lizard brains are notoriously bad at conjugating verbs in a second language.
Terrible at it. That is why you cannot rely on figuring it out in the moment. You need pre-memorized sound bites, hard-coded scripts.
The first one is a number, 911 versus a 112.
This is so crucial. If you're from the US, you are programmed to dial 911. It's muscle memory. But if you do that in Europe, it might not work. 112 is the international standard for mobile phones in many parts of the world.
And it works even if your phone is locked or has no SIM card, right?
Often, yes. So step 1, know the local number, put it in your phone, write it on your arm if you have to.
Okay, step 2.
The imperative command. The phrase is, call an ambulance.
It's very forceful. Call an ambulance. No, please, no, excuse me.
Politeness is fatal in an emergency. If you say, excuse me, I'm terribly sorry, but could someone possibly call for help? People might just think you're asking a question.
Or asking for a taxi.
Exactly. You need to break the bystander effect. You have to be loud, direct, and imperative. Call an ambulance. Signals immediate danger.
It cuts through the noise. And what if you're the one who needs to get there?
Where is the nearest hospital? Again, notice the efficiency. You aren't asking for the best hospital or a specialist. You're asking for the nearest one with an emergency room.
Speed is the only metric that matters.
Correct. And by memorizing these short, punchy phrases, you are bypassing that frozen prefrontal cortex. You're giving your brain a handle to grab onto when everything else is slippery with panic.
That's a really powerful image. It's like having a break glass in case of emergency box in your brain.
That is exactly what it is. And it ties back to the whole theme here. The goal isn't to become fluent in medical English. The goal is to reduce cognitive load.
We have so much on our minds when we're sick abroad. The cost, the insurance, the missed flights, the fear.
So if you can automate the language part, if you know pain is sharp, ache is dull, ambulance is the command, you free up brain power to deal with the actual situation.
The source material wraps up with a piece of advice that feels almost cliche, but after this conversation, it hits differently. Don't panic, speak slowly.
It's the paradox of urgency. We think to get help faster, we need to talk faster.
Yeah.
But that usually backfires. Rapid-fire speech is hard to understand, especially through an accent or a mask.
So slowing down actually speeds up the diagnosis.
It ensures accuracy. If you rush and say ache when you meant pain, you've lost time. If you speak slowly and select the right word, you gain time.
And the final reminder from the notes. Doctors are trained to help you.
I love that. It's so easy to feel like it's us versus the system, but medicine is a universal language. The physiology of a human body is the same in Kyoto as it is in Kansas. The doctor wants to solve the puzzle. You just need to give them the right pieces.
We really have covered the whole journey here. From that first morning wake up with a dull ache, to the sharp pain, the doctor visit, the pharmacy, and the emergency plan.
And notice how none of this required you to be a grammar expert. It just required you to be specific.
Specificity is safety.
That's the tweet. That's the bumper sticker right there. Specificity is safety.
Before we let you go, I want to try something. We talked about the freeze response earlier, and the best way to beat it is rehearsal. So I want to challenge you, yes, you listening right now, to do a 10-second mental drill.
This works. Athletes do it. Astronauts do it.
Imagine you have a sharp pain in your chest. Visualize it. Now visualize yourself walking up to someone and saying, call an ambulance. Hear your own voice saying it.
Then imagine a dull stomach ache. Visualize walking into a pharmacy and asking, do I need a prescription?
It feels a little silly to role play with yourself, I know, but you are building those neural pathways. You're laying the cables now so the electricity can flow later.
And honestly, I hope you do this rehearsal and then never, ever have to use it. I hope your travels are full of great food and 0 doctors.
That is the dream.
Yeah.
But if the nightmare happens, now you know what to say.
Be prepared, not scared.
Thanks for taking this deep dive with us. Stay safe out there, travelers.
Safe travels.